Good afternoon, respected chairpersons, panelists, learned audience. The president of IPDI was lucky to get a few additional minutes, but the vice president will not be that lucky, I hope. So, before starting my presentation, the hypertension in CKD is a complex interplay between the very important two vital organs of the body. It is like love and hate relationship between two influential neighbors. Let me start with a historical note. In the ancient Egypt, when the dead bodies are converted into mummies, they used to remove all the organs of the body except the heart and the kidneys. They believed that these two organs will be useful in their afterlife. But they did not give any guideline about how to deal with the beautiful ladies who are allocated in the heaven to the male persons, virtuous males. So we all know that the chronic kidney disease is an important cause of morbidity and mortality, and it is affects about 10 to 15% of the population, and the 11th leading cause of death, and the estimated prevalence about 276 million. We all know the definition because don't need to, the GFR should be less than 60 ml for at least for 3 months, and hypertension definition we all know. And we must appreciate that hypertension contributes to about 23% of the patient with CKD, and it is present in about 90%, whereas diabetes contributes to about 50% of the CKD. And in stage 3 and 4 CKD, they always confers higher cardiovascular risk rather than stage 5, which is the end-stage renal disease. And lowering of the blood pressure definitely confers better protection. These are the basic pathophysiology. This is the retention of sodium and water leading to plasma volume increase in cardiac output, the subsequent activation of renin, angiotensin, aldosterone system, sympathetic nervous system leading to vasoconstriction and associated secondary hyperparathyroidism leading to intracellular calcium accumulation, reduced vascular compliance, and there is a lack of vasodilators as well. This is the schematic representation of the basic pathophysiology and its influence on the subsequent therapy selection. Blood pressure measurement is we need to do very meticulously, but unfortunately in the COVID era, it has been delegated to the paramedical staff, but in chronic kidney disease, we need to measure the blood pressure in a very meticulous way. And due to this variation of blood pressure measurement, ambulatory blood pressure monitoring has been emphasized as a gold standard. And the clinic reading as well as the home reading, this should be considered, as well as the white coat hypertension and pseudo hypertension should be taken into consideration as well. This is the one important thing, that the blood pressure variability in the patient with chronic kidney disease, we all know that the systolic pressure is higher in the daytime and it falls about 10% in the night time, but this dipping is absent in chronic kidney disease, and this leads to the increased morbidity and mortality. And extracellular volume expansion, uremic encephalopathy, autonomic neuropathy all contributes to this lack of nocturnal dipping. Proteinuria is an important implication in chronic kidney disease, and it confers increased cardiovascular risk. And this is the microalbuminuria as leading and ranging to macroalbumin. Different levels of albuminuria, the higher the level of protein leak, the higher is the risk and progression to end-stage renal disease. These are all guidelines have unequivocally recommended reduction of blood pressure in chronic kidney disease. ACC-AHA recommends in CKD that 132/80 regardless of proteinuria. NICE and UK Renal Association recommend are more less conservative. They recommend 140 by 90 if the proteinuria is less than 1 gram per day. KDIGO guideline, they also recommends lower blood pressure with associated proteinuria. ESC, European Society of Hypertension, they recommend a systolic pressure of less than 140 regardless of proteinuria. And the SPRINT trial also shows that the systolic blood pressure is less than 120. There is a reduction in cardiovascular disease and all-cause mortality. Reduction of blood pressure is not without problems. These are the electrolyte imbalance like hyponatremia, hyperkalemia, renal insufficiency might be aggravated. There may be hypotension, but orthostatic symptoms are fortunately rare in patients with chronic kidney disease. These are the different trials which have addressed the issues of hypertension in kidney disease, MDRD, REN2, SPRINT trial, ACCORD trial. The cardioprotection and renoprotection, they progress hand in hand. So the better cardioprotection is associated with better renal protection. There is no doubt about it. The non-pharmacological measures, all aspects of hypertension we need to emphasize. The daily recommended dose of sodium it should be less than 2 gram, which is equivalent to 5 gram of sodium chloride per day. And in stage 3 and 4 CKD, the low sodium diet decreases blood pressure, proteinuria, extracellular volume. The BMI should be kept between 20 to 25, which is also beneficial for the patient in regards to proteinuria. And aerobic exercise according to AHA, 30 minutes per day, 5 days a week, this is the bare minimum requirement. Alcohol consumption should be avoided if possible, but if not possible, 2 drinks per day for males and 1 drink per day standard drinks for females. And dietary protein intake for CKD stage 1 and 2 should be about 1.4 gram per kg, and it should be half in the other stages of CKD. The renin-angiotensin blockade is beneficial in all patients with hypertension, but in cases of in CKD it is very important in the association of proteinuria, because they have a potential to reduce the proteinuria. And it can reduce the systolic blood pressure in patients with CKD, and it is a class effect actually. No single agent is beneficial than the other, and this is a BP independent reduction of proteinuria, and there is improved renal outcome in RAS blockade. And in patients with 50% patients with SC inhibition, they have reactivation of angiotensin II, which subsequently blunts the therapeutic effect of the drug. Combination of SC inhibitor and ARB is not recommended nowadays because of the risk of hyperkalemia and rapid decline of renal function. So we should be very much cautious about this. There is some transient fall of GFR after initiation of SC inhibitor or ARB, up to 30% rise in 3 months. It is accepted, but we should be monitoring the patients frequently, like creatinine and electrolyte estimation 7 to 10 days after initiation, and potassium therapy, potassium level of more than 6 warrant the stoppage, and more than 5.5 we should be taking the dietary measures. And we should be aware of the use of NSAID, COX-2 inhibitors and potassium sparing diuretics, which all contributes to hyperkalemia. Diuretics is a very important agent in managing hypertension, and because of many of the CKD patients are volume overloaded, they reduce the volume and arterial stiffness. The diuretics, like when the renal function is relatively better, thiazide type diuretics can be used, but as the renal GFR declines, loop diuretic should be used, and the combination can be used as well. And with GFR of less than 30 ml per minute, loop diuretics should be used, like the toracemide, metolazone, like this. And they are not traditional antihypertensive, but they reduce blood pressure by an indirect mechanism. And diuretics should be avoided in polycystic kidney disease because they can accelerate the growth of kidney cysts and leading to reduced renal function. Mineralocorticoid receptor antagonists like spironolactone, epleron, they have shown benefit, and nowadays the third generation mineralocorticoid receptor antagonist finerenone has shown a lot of promise in patients with CKD as well as in LV dysfunction, and it has been proved in the Figaro DKD trial. Finerenone has gained a lot of interest.
Time is up, sir.
And these are the other agents, calcium channel block. These are the order of sequence of selection of drug: ACE inhibitor followed by diuretic, calcium antagonist. Fourth, the stage there is the adrenergic receptor blockers, MRA, and fifth stage is the direct vasodilators. This is the hemodialysis setting. It is sometimes very important for blood pressure control. The 3 sessions per week, 4 hours a session is important. And kidney transplantation, we should avoid ACE inhibitors in the initial stage, but we can prescribe the calcium channel blockers. This is the take-home message. Hypertension in CKD poses a difficult clinical subset. We need multiple drugs in high dose, and the uncontrolled hypertension has poor prognosis, required frequent administration, hospital admission, and sometimes the hemodialysis becomes the ultimate mode of control of blood pressure. Thank you very much for your patient hearing.
Thank you, sir.